watching and they don't usually watch this today is Mr. A. I want to welcome all of our guests. We're streaming on Facebook and we must be at like 6. Never mind. Just talking to myself. Thank you. My wife mentions that sometimes. But anyway, I want to welcome everybody to Disability Advocacy Day. And thanks to the folks who decided to make it virtual. That was actually a really good idea. I don't know. They knew the weather forecast better than the weatherman, I think. So if you're joining us for the first time because of that, welcome. Today will be quite a robust discussion about things. Looking forward, today we're going to talk about, revisit the separation of the Department of Behavioral Health from the Department of Human Services. We're going to hear from the department some of their reactions to our discussion last week. And I just want to make it clear, we didn't not take their reactions last week because we didn't want to hear their reactions. I wanted them to be able to have, premeditated reactions to that. And so they're always welcome to pop in, we are certainly a partnership with them on so many things, and we push each other sometimes and help each other, and hopefully at the end we help the clients, the people who rely so much on what we do. And then we're going to talk today about what's it going to cost to get workforce squared away in Minnesota. And I don't know what the future of all this discussion is going. Personally, my desire is that we could put together a workforce bill with a meaningful impact on how to attract more individuals. We've already set up a proposal to try to draw in 20,000, kind of the entry-level workers, CNAs, et cetera, with $60 million that's left this committee. It's on the way to finance, and it's the full intent of me and I think of the Senate to promote that and to make that come true. And we're open to that discussion. So then we're going to talk today there'll be 3 proposals. We're actually not going to move any of those again today. We're just going to talk about the ideas. And I invite people on the committee and those outside the committee to weigh in with their thoughts. We're not, I don't know who's got the link for it, but for sure in the future, I don't know if you have access to Mr. Yates just now, but he has the magic link. And so I don't know if we'll have time to have a lot of outside discussion, but we really do want to hear not just from the people that are the leaders of the industries and the providers, but the folks that are the people living in these places that we think that are doing well. I mentioned today on the call that Senator Murphy was here probably then. We were hoping to unlock the waiver. And the previous commissioner by the name of Goodnow was part of that process, and there was a surprising amount of people that were outside looking in, 4,000 or 5,000 people that we had no idea there was that many. So we thought if we can just get you into the waiver, you'll be fine. Well, these days the waiver is an empty promise because some of the services you can get look like this. Some places are closing, and so this isn't just this is actually a closed group home in a snowstorm. That's what this is, Senator Hoffman. And so what are we going to do? And so that's very much on our minds, and I want to hear from the individuals, you can share your distress, but I need to know what you think we can do, because I think the leadership for this topic is coming from this table in a bipartisan manner. Next week on Tuesday, we're going to take up some legislation, some bills on some various topics, and Thursday, what are we doing again? Okay, and so we're going to continue the discussion. We're going to, this Thursday, sorry, I'm on my wrong week. So this Thursday, so this is Tuesday, next Tuesday we're going to hear some bills. This Thursday we're going to hear from the commissioner about the RCO discussion, and we're going to talk about more stuff. So, we're going to talk about more of those workforce ideas. That's right, kind of piggybacking on last Thursday, the department's reacting today. And if I get confused, I don't know. I'm not old. Anyway, but we're doing a lot of raw work here on the committee, and frankly, the different discussions that come up, I think are really productive. We do want to talk about, we're going to hear Senator Whitman's bill about substance abuse, and just to get you thinking, as we talk about that, is there a way in some of the treatment programs to entice some of those clients to actually get part-time work? maybe in the industries that we're so interested in. Is there a way, and we're going to do a homeless day is March 10th. We're going to do some homeless hearings with Senator Dibble and some others. Is there a way to entice people who are officially homeless to get part-time jobs and then go back to their shelter and then finally get a ladder out? So those are just thinking, where are people that can work? So anyway, with that, that's trying to be a little vision of the short-term future. Anyway, so today, Senator Eaton was going to come and talk about some states that have actually broken off their behavioral health units to be independent. And in her absence, she's been working with Senator Hoffman to bring that same information forward for today. And we're going to do not more than 20 minutes on the whole topic, including hearing from Mr. Anderson. So Senator Hoffman, 10 or 15 minutes, and then, and is this their handout in our folder?
Yeah, Mr. Chair, there's a couple of different handouts that.
Okay, well, very good. So Senator Hoffman, take it away.
And then I know you have Randy Anderson is here too to look at the perspective from, both he serves on a county advisory board and works within mental health and substance use and on his professional life too in recovery and Second Chance Coalition kind of stuff.
Oh, perfect. And so again, you're going to give us an overview.
Yep.
For digestion purposes for later.
Yep.
Mr. Anderson will come and offer a few
and
thoughts.
I'm going to highlight this, Mr. Chair. Thank you. What brings us here really is addiction is an illness, is social isolation, right? And we really didn't get into the weeds about why we're doing what we're doing, right? And so what has happened with the social isolation, it's dramatically worsened due to the pandemic. And what we've seen is co-occurring disorders affect each other and every other in different manners. And if there's an untreated mental health issue, Mr. Chair, substance use gets worse. Figure that. If drug or alcohol use increases, mental health issues increase, right? So there's this thing, one and the other. The vicious cycle contains and continues, Mr. Chair, until all the areas of those illnesses are addressed. All the areas of the illness addressed. Then I'm going to talk about a couple of states in particular, but I just want to give you another overview about what you're doing within your bill. When we looked at what is the guts of this really doing. And so the AMA reports that in the U.S., right, individuals with co-occurring conditions, this is real stuff. 50% severe mental health disorders are affected by substance use, period. 50%. 39% alcohol users with at least one serious mental health disorder. 53% drug users with at least one serious mental health disorder. Are you seeing the theme here, Mr. Chair? 29% alcohol or drug abuse among all people diagnosed with a mental health disorder, right? And in Minnesota, then, we tie in, and I think it's important that you look at the overdose deaths in Minnesota. Metro area increased 40% from 2019 to 2020. Statewide, there was an increase of 27% since 2019. Here's a couple that are pretty alarming. 57% increase of overdose deaths in the 25 to 34-year-old piece. 59% increase in opioid overdose deaths 2019 to 2020, and that number is climbing. So everything in isolation, right? This is the theme of what you want to do, what you want to bring forward. 81% increase in deaths involving synthetic opioids. Things don't look well. And so what you're trying to do is simply three things, and I'm going to highlight that, and then I'm going to go into the discussion of the states. Behavioral health audience with the governor needs to be one-to-one, right? Right now it's a division. There's 6 layers beneath the commissioner. And as highlighted when the commissioner presented her slides to you and to this committee last week, I noticed one thing. Number one, the director position, there isn't anybody sitting in there now. Paul Fleischner, who was going to be, he was the wonky guy from Olmsted County. You met him the first time he came to this committee and you went, wow, this guy gets the big picture, right? 1 year. 1 year he was in there. Our understanding on the committee was 3 years, right? And so 1 year. And so what we see there is you elevate this position. Number one, you have a behavioral health audience with the governor. Right now it's embedded, like I said, within layers and with 12 other priorities. And very rarely does it have an audience. And I'm going to give you a prime example of that piece. Even NAMI, in a letter, said many years they've had with many governors, they brought many priorities forward, but nothing came across the finish line, right? Nothing came across the finish line. And so what happens, rather than work coming its way up through a division, it has to get through all these layers to get to a commissioner, and then, oh, by the way, it goes over here, right? In a $21 billion industry, what you're saying is, we got an epidemic. The CDC, NIH, the federal government has said, this epidemic is occurring in the states across the United States. So what you're advocating is just taking the division and giving it a priority, elevating that priority, which gets to point number 2, Mr. Chair, is what you're really doing is you're placing that individual at a cabinet member to speak specifically to mental health and substance use, and allows this priority to have a seat, and then that person then can issue their own independent budget. Hence, when we talk to other states that have that person sitting at the cabinet level, they get to fight for their own budget. They get to sit there, and in the case of Minnesota, you would fight with MMB and the governor to say, no, I want this much, I want that much, right? Now it's happening at a cabinet level, which makes sense because that's what's in charge of all the agencies, right? Not us, the governor is. So in this case, the department allows them to make their case to MMB and the governor specifically. Your bill, Mr. Chair, utilizes the infrastructure already existing as DHS. And I'm going to get this point very clear. As such, the Medicaid issue that people are throwing on the table at you is not a factor. And part of that is because the Medicaid money flows to the state from the feds, given authority to the Commissioner of Human Services. And by the way, the Department of Human Services has 42 interagency agreements with other agencies within the state of Minnesota, and one of which I highlighted to you was under the Department of Health, right? The home visiting stuff, it's Medicaid, that's all in there. You're not moving the Medicaid person in there. What you're doing is you're just rearranging the deck to get that priority to the very top of the list. And so, and this more is not directed toward you, Mr. Chair, but so people understand what you were trying to accomplish within this. And the third thing, let me just go back on one thing here. The department utilizes existing infrastructure of HR and legal services, right? It does that now. That's been done under the Minnesota Board of Aging and MNsure. They have autonomy, but they're utilizing the infrastructure of the Department of Human Services. It's a piece of cake, right? Somebody did it someplace else. We did it already. Why can't you do it here, Mr. Chair? As we're saying, third thing, the bill elevates and gives the importance of presence. It's a chronic disease and health care. And I'm gonna talk about, there's a handout you all got from New York Times on the opioid epidemic, right? And in there is one of the folks they talked to was in the opioid report, it was a Stanford report. And the Stanford report has been in existence for 25 years. You ever heard of Stanford University? No? Didn't Denny Green, wasn't our old football, Vikings football coach? Forget it. I'm trying to make the connection, Mr. Chair. 25 years, and they specifically said, and let me just highlight this, what the Stanford report said to you. They came up 7 different recommendations. Recommendation 3A, right? They made a comment. Integrated evidence-based and enduring systems for care of substance use disorders should be built and supported financially, right? And what their recommendation is saying, based on the opioid epidemic, right, and based on the mental health and substance use, is that health and social care systems must make an enduring commitment to provide services to people, right, with substance use disorders. This must be fully integrated with mainstream healthcare systems, right, and be equally accessible. And what they're meaning by mainstream, ready for this? They're talking about hub and spokes, Mr. Chair. Primary care, mental health care settings, outpatient addiction treatment, and clinics specializing in chronic pain management. They're all saying that has to be an integrated approach to it. Right now, it's all siloed, as evident, because we've had the same statistics come out with the same thing for years and years, and yet at the same time, this opioid epidemic and the fact that our substance use and mental health epidemics are going through the roof, right? It's time to really look at integration. Your 3 things that you talked, that I just highlighted for you is there. And the 7 things that this bill simply breaks down, I highlighted in those 3, and it creates a Department of Behavioral Health, right? And it gives that commissioner the authority to appoint department heads, right? That's the second thing. The third thing, we establish salary limits that are already embedded in the law. Nothing's changing within law. You also allow a commissioner to do unclassified positions, as any other commissioner gets to do. And then once created, the governor appoints the commissioner, and there are 4 points established under 245T.01, right? And that's really to look at how that integration is going to occur within the infrastructure that already exists. It's not talking about anything other than that, right? And then you get down to the section that really talks about transferring of duties, right? And what that transfer of duties, and it finally, Mr. Chair, the language in the legislation is really an elevation of this epidemic at the cabinet level, period. That's it. It's not the sky's not falling, the world's not falling. This is really good language, what you put together, and it caused me to do my research like you had asked me to do. And finally, what it really does is you tell then in the transfer of duties, embedded within the construct of that umbrella, you finally then say you instruct the reviser to consult, and you listed who those necessary agencies and necessary people were in order to prepare legislation for the 2023 session that says, how is this thing lining up? So you've created this doorway to be able to say, we want to look at this by taking this division and going up here with it. It's brilliant stuff. So you ask the same question, you say, all right, well, what about other states? Well, as of February of 2022, there are 13 states that have behavioral or mental health departments. 13 states, mental health departments, not divisions, and that are either on their free-standing or separate entities, right? And quickly, I'll list Alabama, Connecticut, Georgia, Massachusetts, Mississippi, Missouri, New York, Ohio, Oklahoma, Rhode Island, South Carolina, Tennessee, and Virginia. It's kind of like that song, remember that song? Thank you, Toby's. See, they remember that song. I would have done it. Anyway, the thing that really comes into play here is that the survey that I found when I looked at all these states, right, is that there are 16 key administrative functions from eligibility policy to fraud and abuse, right? 16 key administrative functions. This is important because everybody says, not everybody, but people, the naysayers to your bill, which is a brilliant bill, by the way. I got to tell you that. And so it's supposed to be funny, but it's not. There are 16 functions in Medicaid, right? And so there are only 5 states, Colorado, Illinois, Massachusetts, Minnesota, and Nebraska, that does the full spectrum administration of all 16 functions, right? 29 of the states in the United States contract one or more of the 16 functions to a private sector. Now, I'm not for privatization, but I will tell you this, the most contracted piece of all those 16 functions is the Medicaid Management Information System, the MMIS system. Isn't that, you find that kind of odd? So you wonder why we're looking at a $21 billion department and saying, are all the priorities of this somewhat small part of the department, DHS, not getting elevated to the top? Again, I'm going to highlight that PowerPoint that was presented last week showed exactly why there's a missing document in there. It needs to be extracted out. So the 3 things that I highlighted for you, Mr. Chair, are exactly what's important. So when we look at a couple of states, I'll give you one example, and then I want to get Mr. Anderson to kind of talk about his perspective on this. But even within our own state, Mr. Chair, you had a presentation or a letter from the association that does the Excellence in Addiction Care, Association of Addiction Care, inpatient, outpatient folks. And they even said the intent of what you did is to lift up and address the growing crisis of disease and addiction in Minnesota through development and implementation of an inclusive, comprehensive response during this critical time. It's lined up. On the federal level, they're saying we're in an epidemic, right? Stanford's saying it's got to be integrated, right? 25 years, I guess Stanford doing what the New York Times saw it. I got the New York Times, but the fact is that's where the Stanford folks were when they were talking about this 25-year capacity, and they're looking at it saying this is what needs to happen. It's got to be integrated, and you've got to include primary care, mental health, substance use. It's got to be. Right now, that's not what's happening in Minnesota, right? From what I've seen in the presentations, Mr. Chair, and what you're talking about, the concern that sits out there, that's exactly what's happening. And so the other thing that the inpatient, outpatient provider said to you was, we support reform that ensures Minnesota has a singular, elevated, and coordinated approach coordinated approach, comprehensive, coordinated. My 3C started coming into my Public Law 99-457 discussion, which we've had for 20-some years. But the elevated and coordinated approach across substance use continuum of care. Now we're talking Senator Murphy's continuum of care, nursing services. That's right, the whole thing about continuum of care. Where is this whole perspective on the public health side of this? And it absolutely hits in there. And this approach, Mr. Chair, must include education, prevention, treatment, support services, and recovery. It's a continuum of care. It's a non-siloed approach. It's bringing all those things collaboratively. I love what they said in that letter. And then what I really like is it is beyond time. And Senator Eaton said this when she first presented the bill that you two are on. It's beyond time. Minnesota has a plan that utilizes a full continuum of care that can be managed and implemented. Okay. Well, other states aren't like Minnesota, and they're saying, oh, it's tougher. We want to be more like Minnesota. Well, when you looked at those 13 states, I'm going to one for example. Is some of the stuff in New York City, people were talking about wanting to integrate or not integrate, and they have one portion of it, but they really wanted to do the umbrella. And they were getting the same pushback from the bureaucrats and from those that are operating in silos regarding, and here's what I've seen. What they've seen in the departments, there are silos that are priorities that do not get raised to the surface, right? And so the protocols in the state of New York ended up being fragmented, right? And so, I mean, there's more to that, but those are the kinds of conversations we're getting from states. Those that are doing it well are doing it well. Those are struggling with the fact that there's still a bunch of folks that are saying, oh no, we like what we're doing. You know, and if I haven't convinced you that your bill makes sense when it comes to those three things it's doing, it's just elevating the priority. And this is what the governor, he absolutely talks about addiction and mental health. He's always talking about it. This gives him authority to be able to now place that as a priority in the state of Minnesota. I think it's wonderful that we're having this conversation. I'm glad I could be part of helping you understand what the lay of the land is, Mr. Chair. Is that okay? And with that, I think Randy Anderson is here to chat with you as well.
Well, thank you, Senator Hoffman. I think that was really enlightening. And what we're trying to do here is create a thoughtful discussion. And I think, Senator Hoffman, you really lended a lot to that. And so we're not taking action today, except action to create a discussion. And I hope there's discussions in the hallways. Mr. Anderson is here, and in a second we'll let him talk for a couple minutes. But I like, I think when Senator Eaton was here, I think the most salient point was she has pretty much a career in working on this after a tragic loss. And after all the task forces and laws and money, she said, it's not working. And so at least you would hope that here's the number that started and then we're kind of seeing an attrition. And so there's fewer and fewer. But in fact, it's the inverse. There's some and then we're actually getting more. And so I think that in the most friendly of ways and not judging anything, but maybe we should do something different. And bring in all those great minds. And I just have one more thought. So I was thinking, you mentioned the commissioner at the cabinet level. And so I could just imagine, and Commissioner Harpstead has been amazing to work with. I think she has been an exemplar of collaboration with the four chairs and the legislature. But I think, Commissioner, if you'll forgive me, I think you go into the governor's budget discussions. And so, yeah, I need some health care. Long-term care, it's a problem. Disability services, what do you want for that? $1 billion? Okay. I need $1 billion of that. We need child care, $1 billion. Substance abuse, $500 million. And they're like, what do we do with that? Oh, MSO, yeah, they got sex offenders, we got county services, we got, and whoever I forgot, I'm sorry. And they're like, really? You can have $555 million this time and $2.2 billion next time and spend it how you want. And so I don't, and it's, so Senator Hoffman, yeah.
May I just add to that? And you know, one of the things that Senator Eaton had said back in 2014, and she actually reminded me of this, she said, And it's nobody's fault but our system, however we set it up. I blame you. You guys, the 1990s and in the early 2000s who set this stuff up. And there's 3 of you in this room. I'm trying to be funny, but it's not. The piece she said was 3 governors, right? Multiple different commissioners had said to her, we are going to look at this, we're going to fix this. Multiple tests. She said it, from the very beginning on that, right? And yet at the same time, we still have, we still have people dying every day, right? It's not okay.
More people dying.
More people, and the evidence is there, and so with that, Randy.
Anyway, so for homework, if folks would look at this document, which has the 13 states on it, tragically, the article that's with it is just more news about what we all know, and drug overdoses now kill over 100,000 Americans a year. That seems like a lot to me. That's just seems tragic. Anyway, Mr. Anderson, welcome to the committee. Just a couple minutes on what you're thinking today. It's nice to have you back.
Thanks, Senator, and thank you, Senator Abeler and committee members, for having me here today. I don't think I'm as eloquent in my speaking as Senator Hoffman, so I wrote my thoughts down to make sure I'm succinct and in a timely manner. So my name is Randy Anderson, and I'm a person living in long-term recovery from substance use. What that means to me is I haven't had any alcohol, drugs, or mood-altering substance since January 9th, 2005. And because of my recovery, I'm able to have healthy relationships, own a home, run a successful small business, vote, and even pay taxes. I'm also a Minnesota State licensed alcohol and drug counselor, a peer recovery specialist, and a formerly incarcerated person who was sentenced to 87 months in prison as a first-time nonviolent drug user with little to no criminal history. I started my small business, Bold North Recovery, in 2019, primarily to work outside of the huge bureaucracies that exist. I consider myself to be very lucky and privileged to do the work I'm able to do today, especially when it comes to advocacy and finding help in the community for people struggling with substance-related issues. The second part hasn't always been so easy for me. Navigating our current system can be one of the most difficult tasks for anyone trying to find help for themselves or a loved one or a friend. I've worked in the substance use disorder field since 2015, and one of the most frustrating things for me has been not knowing who has authority over what. I work with small providers daily that tell me they feel like no one is listening. Just yesterday, I spoke with a very good friend of mine who runs a small licensed program in the metro area, and she told me she asked some questions of DHS back in October, and no one has ever gotten back to her. I would like to tell you that yesterday's conversation was unusual and only happens once in a while. However, it is not, and happens nearly every week in my world. When talking to my network of small and large providers in the SUD field, there is one common theme. DHS is too big, and they wish there was an agency or a department where they felt heard, more included, and better communicated with. I do support Senate File 2845, which would create a department that has substance use and mental health services as their only duties and priorities. And today I also I looked up a couple things out of curiosity, and in 2015, the Annals of Internal Medicine published a story or an article that said mental health and substance use disorders are estimated to surpass all physical diseases as a major cause of worldwide disability by 2020. And to update the numbers, 288 people died from overdose during the 12-month period that ended September 2021, marking an increase of nearly 16%, or roughly 14,000 more than the previous year. And one of those was my stepfather, who died of a fentanyl overdose in September. And so this is important to me, and this does mean a lot to me. So thank you for allowing me to share my thoughts with all of you today.
Mr. Anderson, thank you. And I just want to emphasize something, and then we'll take comments from members, and then we'll move on. This is not a way to cause any harm to DHS or impugn their efforts. These are people who are co-partners in a way to try to make it work. And it's curious enough, given the snow, we have 2 former commissioners in this audience. That has seldom happened. Yeah, there you go. There you go. There. Anyway, it's a privilege to have you all here, and they can tell you that we're not going to call them up, but not to embarrass them, but they would tell you how hard it is to try to juggle all those balls despite their best intentions. So, Senator Murphy.
Thank you, Mr. Chair. And Mr. Anderson, thank you for your testimony. And I want to let you know that I too have almost lost someone to fentanyl. Gratefully, I did not, but I'm sorry for your loss, and I'm glad you're here. And I hope you will stick with the committee process this year as we work our way through this issue. I wanted to thank you. And it's also good to see commissioners in the office, or former commissioners. I've worked with them both. My question is really to the chair, to the author, and for the committee to consider on this proposal. And when we had our first introduction to this issue, I did raise for the committee's consideration the idea that one of the issues I think we face, bureaucracy aside, is the way we consider substance abuse and mental health disorders like we consider an episode of other treatment. So as we consider someone has a bad gallbladder and we're going to take care of them and they're going to have surgery and they're going to get better, we have figured out how to do that. But these conditions, these physical conditions, don't fit neatly into that box. And so when I think about this proposal, the first issue that comes to mind for me is I understand this proposal is just really setting up a new department. But I would want to know, would it be this new department that would have the responsibility of establishing contracts with the health plans that deliver through Medicaid, medical assistance, and Minnesota Care the terms of care and treatment for people with ongoing conditions such as substance abuse and mental illness? Because if we're not able to get to that level, I don't know that we change in a material way the outcome for the people who are dealing with these ongoing conditions. And as former Commissioner Ludeman and I worked long ago together with a group of people who were very poor, in part because of their health conditions. They were sick. They had multiple conditions, including mental illness, substance abuse disorder, and it was the reason for many of the indicators, the reason why they were poor, why they were often homeless, why they were in and out of the system. That is part of the root problem that I think we need to solve in this conversation, and this proposal doesn't yet reach there. I understand that, but I want to continue to raise it, because if we're serious about advancing health, then I think we have to dig down further beyond the bureaucracy. Not saying this isn't the right move, just saying that it's not the complete move. Thank you.
It's a really good point, and I think it's salient. I wrote it down. Just to remind, I haven't thought about this till you said what you said, but so how many departments does Minnesota have? Like 20 or something. We have transportation, we have education, we have, human services, we have health, we have, whatever, public safety. Is there any of us think that any of those operate in a vacuum? And in the best of, it's just one way to organize. Do you think a person's public safety is independent of their transportation, independent of their ability to work, like deed, or to get child care, or to enjoy their retirement, or to have state employees serve all those? It's just a division of how we decide who's going to do what. I think as we go forward, we'll need to look and see how these 13 states handled some of those questions. But if indeed DHS has 40-some interagency agreements, I just think we're on track. And I think provoking the discussion, I'm glad that people are being drawn into it. I think it's really important. So, Senator Huffman, get the last word, then we're going to move on. Thank
you, Mr. Chair. And to that point, and thank you, Senator Murphy, for bringing it up. There were seven things that Senator Abeler's bill is doing, and the fifth one really addresses, when you look at the intention is to not create a second Medicaid agency, rather it's to integrate and intersectional the various activities that are associated with the delivery of those services. In that section of the bill, it says, for example, things that'll be need to address by agencies are like the Department of Health oversees all the behavioral health analysis and should be kept those should stay the same, right? Same in point with the Medicaid provisions under the Commissioner of Human Services, right? Because that person has the full authority on the payment when it comes to the federal payment side of it, right? That's addressed in there. And then in the sixth point, the sixth section of the bill, then not only that, in the transfer of duties, there's more explanation on what that is. And then finally, the seventh point is saying, okay, well, what's left over, right? Then the revisor's office and those other folks that are listed in there, which is the old House people, the Senate people, the everything, need to come up with a what's missing piece on it. But you're driving point something that's so much critical importance in here is that whole thing of continuum of care. When the Stanford folks looked at in that article from the New York Times, go ahead and click on that Stanford thing. That specifically it becomes that it's a healthcare model. I mean, you are absolutely spot on. It's a disease is a disease is a disease. Why aren't we doing this the same way we're doing everything else? And so, absolutely, those conversations must continue. I think Senator Abeler's language in here addresses that to say to all the commissioners when they're at that level, okay, who's going to answer the doorbell? Who's going to answer the back door, right? And stuff like that. It's going to address it.
Cool.
So thank you.
Yeah, so very good points. Senator Hoffman, for your enthusiasm. I think the bill might need a little work, but at least the concept is there, and I really appreciate you digging in. Senator Wickland.
Thank you, Mr. Chair. Thank you. I just, a couple comments. I think there's a lot more information that I would need to know before I felt like this would be something that I could support. I mean, I think that the discussion about how we're connecting behavioral health, mental health with physical health, I think that is a big question for me because we've seen a lot of work go into how these all need to be interconnected in the treatment and the addressing of concerns for people. And we've already done work to integrate care in a way that people are able to get behavioral health and their physical health needs met. A lot of the co-occurring comorbidities are physical health related along with mental health and substance use as well. So I'm not sure I see how we can separate out a department and then still have effective ways to integrate those issues or those concerns. And then I think if we're looking at administrative duties, we want to make sure we're looking at where we can gain efficiencies and not be duplicating efforts that could be done in one way, one time, rather than having another entity that has to create a process for the same thing. So if we get more information about other states and what state is really a good model for something that we would want to look at, I'd want some more information about what makes that state a good model to look at. So those are some of the concerns I still have about this bill. Thanks.
No, I appreciate that. I'm just going to remind all the public, if I can talk, sorry, don't get old. There's 13 states with websites listed on this document here. And so I would really appreciate the discussion to be, how does one state do it compared to another state, which is the better model that they're actually doing this. And so otherwise, if we don't do anything, we're going to say we're comfortable with more people dying from substance issues and mental health issues than ever before. And just because it's too hard to figure out, we'll save it for somebody else. And I think this is us today. And so so take a look at this. And so, and maybe, I don't know if anybody's interns want to work on something, create a model that out of all these, and we'll make a hybrid for us. Thank you, everybody. And so just a final thing on this, the commissioner is coming on Thursday to talk about RCOs, recovery community organizations, which I think could use some improvement as well. And if she likes, she's free to take up this topic, not to pressure her, but it would be interesting to hear her take on these 13 states. And by the way, if there's any way, we're moving into post, shutdown world, it is so pleasant to look people in the eye and have a conversation. It is superior. And so we're pretty spread out here, and so just for members to come as you feel comfortable, but it's just better. Otherwise, we used to see the corner people at DHS, and I see just a bunch of boxes with the microphones and the cameras turned off, and so it's not personal. And Commissioner, if there's any way you can come in person and chat with us, you can sit alone and be distanced if that's possible for Thursday. If not, I understand. Okay, so the department, Mr. Burdick, I don't know who's queued up to chat about this. Is there a document you've given us to look at with your comments about last Thursday's discussion? So whoever's going to lead on that. Mr. Grom, oh, hi. Welcome.
Hi, Mr. Chair. Thank you. For the record, my name is Christy Grom with the department. I do not have a document that I've provided the committee with, but I can just provide some general comments about the bills that were heard last week and then maybe walk through each of them specifically, if that would work for you, and just provide some specific comments to each of those.
Yeah, we were hoping for,
so.
and so maybe like a high level, see what you can do in 10 minutes. Is that helpful? Just kind of see which ones make sense. We've spent a little more time on this first topic than we thought, and it's worthwhile. And if you need, a little more time than that, that's fine. And so just your general reaction to the ideas, and I know you're a little hamstrung because those aren't, governor's policy positions, but Sonia, you just do what you can between now and whenever. So thanks. Go ahead.
Sounds great, Mr. Chair. Well, I'll be brief. So just to start off, I would say we really do appreciate your passion and the committee's passion on the topic of workforce. It's certainly a priority that falls quite high on our list at the department. So really happy to see all of your ideas and to hear your discussion. I think over the past few months, we've been in conversation with stakeholders on many of the ideas that were discussed last week. And we've had an opportunity to provide some technical assistance and to provide some feedback already. So we are by and large really pleased with many of the ideas and how they're shaping up. We know that there's some more work to do, but we'll continue to collaborate with stakeholders this session and beyond to make sure that we're coming up with some solutions that make sense. This is a really complex problem. It's not going away anytime soon, so we're really appreciative of your partnership. In terms of the first bill that was talked about last week, Senate File 3128, this is a bill that I believe Senator Hoffman carried related to children's out-of-home respite and provider co-sign leases, rate changes for particular waiver services. There's a few parts of that bill that are more related to background studies than I can speak to, so we'll have to get back to you on that. But overall, okay with some of the changes in this bill. So related to the individualized home support unit changes, that's something we're neutral on. We've provided some technical assistance. I know that providers have worked on this provision. Last year, they had brought forward an idea that was a little bit unsettling to us, but they've improved upon that idea this year, and so neutral on this position. One thing to note is that this particular measure will require a significant amount of work in MMIS. CMS doesn't have a code for an hourly unit, so we'll need to probably need some extended time to be able to implement this.
Okay.
There's a provision in this bill that moves the, excuse me, getting old also, moves a unit-based, a 15-minute unit-based respite rate to, instead of having a framework based on cost components, to make it a market rate that would be negotiated with a county. We are neutral on this particular provision as well. And then finally, I'll just note the one provision that we do have some concerns with and would like to continue conversations with you and with stakeholders is related to the co-signed leases provision. This is something that came up last session and we had expressed our concerns then, so probably not news to anyone, but this is a provision that would allow a person living in a community setting to have an additional extensions on their provider co-signed lease up to 10 years. So we have some policy concerns with this approach, kind of circumventing what it means for someone to live in their own home, and essentially leading to providers having kind of automatic control over a person's living arrangement for up to a decade. So we haven't actually seen any extensions requested by providers, so we don't think this is an issue right now that needs to be addressed, but have some ideas on maybe addressing it and coming up with some compromise. Senator Utke has a bill, Senate Bill 2968, related to workforce. I believe this is another ARM bill. So this bill would remove the requirement for community residential settings to obtain the alternative overnight supervision technology license. This is a specific license that CRSs have to have. And then there's provisions in the bill that would establish scholarships, childcare, retention grant payments for some workers. We've met with stakeholders on this bill. In terms of the grants, we really support this policy direction. It's similar to some of what's seen in the governor's budget recommendations related to workforce. Overall, we would like to see all workers included from this labor pool, so personal care assistants as well as waiver workers. But other than that, we're supportive of the policy direction. When it comes to the alternative overnight supervision, I did want to spend a little bit of time. This issue falls more into the licensing jurisdiction of our department. So we've been in conversation with licensing to try to make something work and provide some technical assistance that will meet the ends of the bill author and the advocates here. But I just did really want to clarify for the committee that we do allow for technology to be used for our waiver services, for other services for people with disabilities. So I think a lot of the conversation last week centered around kind of the general topic of technology, and we are a technology first state, thanks to many of you. That's in the law books. And we've made a lot of changes in the past few years. We've got remote waiver services that we initiated on our own volition as part of the Waiver Reimagine project that are available now under the waiver services. We had a report on technology that was released, I want to say last summer, with a bunch of recommendations that we'd love to continue working with the legislature on. But this particular clause in the bill is just about removing a licensure requirement, which is something that we're working through. We want to make sure that we can maintain those health and safety assurances, but maybe streamline them a bit so it's not burdensome for providers.
Thank you.
Life sharing, this bill didn't, I don't know if you want me to go on.
Please.
Senator Abeler?
Yeah, keep going.
Okay. So the life sharing bill, I didn't have a file number last week. I'm not sure if it's been introduced yet, but life sharing is a concept that we've been working on for quite a while at DHS, and it does align with our policy direction. We don't have a discrete waiver service for life sharing, but we've had published guidance for probably close to a couple of years to support and encourage providers to utilize this model. So I think one of the questions that came up last week was, why can't we do this and why does it cost money? Well, we can do it, and we didn't need to do it with legislative authority. So we already have this option available for providers, and we are working to encourage this model. I think it's a model that is really important as a new option in the continuum of services, a more relational option for people. Sometimes our family foster care homes almost look exactly like a group home where there's shift staff coming in and multiple people. And so that's fine if that's what someone wants, but to have another option that's more relation-based, more family-focused is something that we think would be of great benefit to people using our services, and certainly something that would support the workforce crisis.
And Ms. Grom, just to that, and so you're doing great flying through these things. If there's some of these ideas that people can do, they don't know it's an option, I think that would be helpful as well. And you're kind of covering that, but on this life sharing, I'm curious then what's novel about it, and so just later, but just if there's some ways to do some of this stuff, I hear your positive approach, so thank you. We'll talk about it some more. Keep going.
Thank you, Mr. Chair. Yep, we would be really happy to talk about it more. Moving to Senate File 2772, this is your bill, Senator Abeler. This is, I believe, it's an increase in the amount of hours that a parent of a minor or spouse can work when they're providing services under community-directed community supports, or CFSS, Community First Services and Supports, which is going to be the new PCA once that gets off the ground. This is something that also is very much in alignment with the DHS policy direction. In fact, we actually authorized some of this when we had executive authority under the governor's executive authority during COVID, the public health emergency. So we've worked with stakeholders on this bill. I think there's some technical assistance that we've offered. I know the other body is really excited about this bill, but overall, we think this is a great idea, and really finding ways to support parents and spouses when it's often difficult to find any worker right now. And so this is an approach we want to continue to look at in alliance with our policy direction. I think it's also an important approach when it comes to providing culturally responsive services.
Well, Ms. Grom, you just kind of make me think, we just passed a waiver bill off the floor. This was a COVID waiver, the whole bill, that 2772, you could go from 40 to 60, or just there was some reasonable extension, or what was the waiver specifically that you mentioned that was in effect?
Mr. Chair, that's a great question. The waiver didn't apply to CFFS because that wasn't, it's not ready yet, but the bill is looking proactively at that becoming available. And I don't recall the cap on the hours that we used. It was in guidance, but I can go back and get that information. It does have a small cost. So I think maybe that was part of the reason why that wasn't included in the COVID waiver extensions, but I think it makes sense to do this ongoing in a permanent fashion. Well,
and Ms. Grom and the other body's not here right now, but it seems if the cost is pretty de minimis or small at least, this could be a stopgap for some of these families that are just totally collapsing with their need for services. So if you could figure that out, and we could maybe get a meeting with Chair Schultz and talk about that. So anyway, I'm going to put a big star on this one. Keep going, Ms. Grom.
Great. Thank you, Mr. Chair. Moving on to another one of your bills. This is Senate File 2773. This is the DWRS employment exploration rate change. I don't have a ton to say on this one. We're neutral here. This is really changing out a Bureau of Labor Statistics code in the rate calculation. We don't have any data to suggest that there's a need for changing this rate or increasing this rate. I think there were some changes made a few years ago related to an MOU that we have, I think, with Deed, and a few, I think maybe that had instigated this conversation, but since those changes have went into effect with our MOU, we haven't seen a decrease in utilization to my knowledge, so I'm not sure that this is needed, and I think, we do have cost reporting coming up, which will give us more information to really assess what these rates should be, not just for employment exploration, but the other employment services. So overall, neutral on this one as well.
Thank you.
And then lastly, the Senate File 2974 is a bill that was brought forward, I believe, by the ARC and by Disability Law Center. We support, this is adding a bunch of shared services to the current, the shared services that exist right now under our waivers, and making some changes around service terminations, as well as looking at some funding for additional training for county case managers when it comes to supporting better coordination, especially for people living in their own homes. We do support the policy direction of this bill as well. We've met with stakeholders on this for quite a while. We have quite a few shared services that are already available under our waiver plans, so we need to work with bill authors and the stakeholders to make sure that the construction of the bill makes sense and doesn't exclude some of the current services that we allow to be shared. And then I would also say, just lastly, trying to be brief, the funding that's available in this bill for to develop more curriculum for county case managers and support workers to do a better job of kind of coordinating services for people, especially when they struggle and they're in their own home. They don't have necessarily a worker that's on hand all the time to answer questions, I think is really critical. And I think, we've got our case management redesign project at the department that the legislature funded the very first stage of that last session, but we have a lot of work to do when it comes to case management and making sure that our counties and our tribes have the support that they need and the resources that they need to do a good job of care coordination for people, especially as we're experiencing the workforce crisis and people are losing workers or people aren't showing up to their job. People really need dependable care coordination in place. So we support this funding, and hopefully we can do some more change as a part of our case management redesign phases in the future.
Well, thank you very much, and I just have a question. Does the policy, independent of the training money, does this bill have a fiscal impact? Just on the merits of the rest of the pages 1 through 8, or 1 through 9? Do you know?
Mr. Chair, I don't know if the shared services have a fiscal impact. I would have to defer to my fiscal colleagues. I'm not sure if any of them are on the call today,
well,
but we can certainly get back to you today.
No, that's fine. I'll talk to Mr. Albrecht as well. But it may be not too much if you're already doing it. Well, that's really very helpful. And just so you understand, Ms. Grom, what we've just accomplished here is these meetings usually take place in the chairman's office or with the individuals who are working on these projects. And so I'm trying to make this more of an inclusive process, and so thank you for being part of history. So that's couldn't happen to a better staffer. So any questions for Ms. Grom? Senator Hoffman has a question.
Thank you, Mr. Chair. And what prompted me was last year, Representative Pinto, we had a bill, child protection and trafficking, and I think it was Jennifer Sommerfeld. I thought it was part of this ongoing moving piece. And maybe Christy, do you know, did we have that part of this discussion in this greater collective, or is that something that we still need to bring back in front of? I know it passed out of here. You remember we moved it. We had the conversation, and it was.
Ms. Grum.
I don't know. I'm confused, but it just prompted my head going,
Senator
well, as
Hoffman's
long as we're having that
confused. Can you help
discussion,
him,
I'm
Ms. Grum?
confused. Help me be unconfused.
Mr. Chair, Senator Hoffman, I don't know that I haven't answered. So just to be clear, your question is about a child sex trafficking provision?
Yeah, Mr. Chair. Yeah, Christy, there was, Dave Pinto had established it in the House, and I think it was coming out of Jennifer Sommerfeld's division in DHS, and we had it here, and I thought it was in these ongoing conversations, and that's all. If you don't know,
I think we'll take that
then
offline,
we'll just take it offline and figure it out.
You're
So
off the
thank
hook,
you.
Ms. Grum. Anyway, and so part of why I waited for Ms. Grum to come today was so they could kind of think it through on some of these questions that we were asking. And that was, I think, a very effective 12 minutes, Ms. Grom. So anyway, so let's move on to something else. And then, so the question is, the hard question, what's it going to cost to salvage the industry? And I don't know who's up first. So if Mr. Goodnow wants to come up to the table and start getting settled there, we're going to go through 3 bills, and we've got, I don't know, half an hour or so to do that, which is probably plenty. None of these ideas are very new. But so let's just say leadership, whoever that is, says, well, how much money do you need to solve your problem, just to make this system intact? We proposed $322 million in kind of a rescue fund package, which we discussed quite a bit in this committee and is now on its way to finance. And to get some $1,000 per person retention money for 206,000 people, $3,000 for training and hiring bonuses and some other monies, which everybody says, well, it'd be great, but it's, we need more than that because that's just a start, and we all agree. So the question, I have no idea what, the number is bigger than I would care to imagine, I imagine, but, so these 3 or 4 topics we're going to discuss today are our effort to get around the question about what will it take. And just to set the tone and so to get enough zeros going on, if we had $1.2 billion to spend in the next 3 years, that'd be $400 million a year. You go like, well, that's a lot of money. So if there's something over 200,000 workers in the long-term care system, PCA, DSPs, nursing homes, et al., group homes, that would be $1 an hour in the base to give 200,000 people $1. And we all agree that wouldn't really do it. So it's like, oh my goodness. Anyway, so with that, just to help you in your aha moments, Mr. Goodnow is going to enlighten us today. And so why don't you take a few minutes to outline we're not going to go through sections. You're going to talk about the basic ideas like you did last time. We're not going to move the bills. They're going to be sitting here. And so, Mr. Goodnow, you know exactly what I'm looking for, so thank you.
Thank you, Mr. Chair, members of the committee. It's a pleasure to be here today. And your little talk right before I got here reminded me of a song that used to be, if I had $1 million. Now I guess we have to change. And we know that inflation's impacted us because now it's, if we had $1 billion, what would we do? So anyway. my mind's going weird, going out
Sorry,
there too,
yeah,
so.
I
You know how
totally
it
get
goes.
where it's going. I'm sorry, I understand that.
Likewise, Mr. Chair. So members of the committee, my name is Kevin Goodnow. I'm here on behalf of the Minnesota Organization for Habilitation and Rehabilitation, which is a group association of day service providers throughout the state of Minnesota. And I'm also representing the Best Life Alliance, which is a broader coalition of providers of services and advocates of services for people with intellectual and developmental disabilities. Thank you for having me here today. I'm here to talk about Senate File 2771, which is a bill that we see as a partial solution to the crisis that we're dealing with right now and a partial long-term solution to that. So when we talk about this bill, what we need is an infusion of money into the industry in order to allow them to hire people and be competitive in the job market for the direct care, the direct support professionals that are out in the community and provide services to people with intellectual and developmental disabilities. Home and community-based services the rates are established through a system which we have put into place a number of years ago called the Disability Waiver Rate System, and DWRS. For those that are new to the committee, you will hear about this every once in a while, and it's my pleasure to be back to talk about it again. So I know you've missed me, Mr. Chair. The bill itself, it's an 18-page bill that actually does three things, but actually does three minor things. It does one major thing. The major thing is it increases rates to provide providers additional funds to hire those direct support professionals. In the system, the disability waiver rate setting system that we have, that's a statutory system that's put into place that basically develops and has formulas in law that determine what the rates are for these services. Different components of those formulas make up, you can modify a different one of those components to actually get the rates, increase the rates. Unlike some services, we can't just say we're going to give you a 10% across the board rate increase because we need to get CMS federal approval in order to get those rates increased. The way we need to do it is work it through the current formulas that are in statute. And so this bill will do that. It does it in three ways. Number one of the elements within the bill is that every 2 years, statutorily, there's an automatic rate adjustment that's based on the latest cost reporting information that has been provided to the department. That information and the data they use to make that automatic adjustment looks at data that is 30 months old, 30 months and a day old, actually, so 2.5 years old. What this bill would do is make it the most recent. They would use, rather than 30-month-old data, they would use the most recently available data, which from practical purposes in dealing with DHS is about seven-month-old data. So we would increase the validity of the data or the currency of the data by two additional years. What this does in the system, the next time the inflationary adjustment is made, you would get an adjustment that would be equivalent to 4 years worth of inflationary cost adjustments rather than just a 2-year period. So that it'll give you one bump at the very beginning, and then after that, it'll follow that 2-year cycle after that. The second thing that this bill does is a number of years ago, in order to recognize the difference between the wages paid to direct support professionals, those who are providing services to people with intellectual and developmental disabilities, and other people who are employed in other occupations that need similar skills and training, there was a differential of, one of the studies showed over 15% differential in the pay rate between those two groups. The DSPs were on the low end of that. In order to recognize that, there was a competitive workforce factor that was built into that formula that tried to close that gap. We only put in about 4%. We closed that gap by about a third or less. What this bill will do is we'll make, every time there's an automatic adjustment in the system, we'll automatically adjust that competitive workforce factor so it goes to, it closes the gap on the differential. This, in our estimation, would result in at least a 10% rate increase when it's fully implemented, because we're not capping it. It's a full implementation. Now, going forward, if that competitive differential it gets closer, that adjustment will go down. But it will get us there in the beginning so we can be competitive with the other folks out in the workforce. Finally, a relatively small provision is one of the things that we're noticing as we do the automatic rate adjustments and also have the application of the competitive workforce factor to the direct support professionals, is that those folks who are supervisors of the DSPs, there's wage compression that's coming in, and it's actually very difficult to recruit and retain supervisors now because the rates that we're paying, or the wages we're paying them are, in some cases, the rates we're getting reimbursed for supervisory services are actually less than direct support when those adjustments take place. So the last element we're doing is we're applying the competitive workforce factor to those services as well. Mr. Chair, that's the bill in a nutshell.
Well, thank you. And so I think this is, if there was a bill to adjust DWRS to fix it to the best extent possible, this is kind of like the full meal deal bill.
This
right?
is, Mr. Chair, members of the committee, this would be you would get a meal out of this. It wouldn't be the full meal deal. We didn't get too carried away. A couple other things. The disability waiver rate setting system is based off of statewide median data. So it's not actual data like are used in some of the other industries, the cost data by provider, but every provider has to work under these estimates of what the costs are. They are working on getting additional data. So other things that could be done, use the metro average median rather than the statewide median. We can tweak it in a lot of different ways, Mr. Chair, is what I'm trying to say.
Right. But so this bill is not cheap, I know that. So I appreciate them. Those are the questions I'm asking. And so
Yep.
even if we did this, it's not going to solve the workforce thing, but it's going to at least, it'll be a big step forward in that.
Mr. Chairman, our problem is twofold. One is being able to compete in the job market with other employers to compete for the people that we need for these jobs. The other challenge we have is just having those people, period, in the workforce. Right. And this will solve the problem with it will partially solve the problem with making us competitive with the other employers. Finding the actual bodies is more of a challenging part of it. So,
Mr. Goodnow, so I don't know if a DSP, do they get $14 an hour?
Mr. Chair, I'm not exactly sure. I think they're in that range depending upon how long they've been in their experience. And I know those wages have gone up because of the current crisis.
Well, let's just say it's 15 and being optimistic, and it's amazing to think that 14 is, hey, look what I've gotten up to.
Right.
Anyway, that's frightening. But so what do you think the wages might be under this legislation? Would it go to 20?
We in talking to our folks internally, we think with these adjustments that we would be able to bring those wages up to that level, to $20 an hour.
So based upon this bill?
Mr. Chairman, that's our best guess.
No, I got it.
It's not as straightforward because it's yes,
So,
Mr. Chairman, based on our best guess.
So back to the meetings in the office. I think I need a fiscal note on this bill, Mr. Albrecht. Okay, thanks. Any questions? Senator Hoffman, DWRS, how could you avoid that?
How could I avoid that?
Where's Senator Rosen when you want her?
Where's Rosen when you need her?
That's not even funny to anybody else.
Nobody.
Go ahead, Senator.
Kim Norton, didn't Murphy put Kim Norton on this with you over in the House in that 2014?
That was funny.
So, interesting, Kevin, if you change how the methodology for, getting that rate setting, and if it increases, the state's gonna have to put an X amount in that. Is that up for the federal match then? Does that fall underneath the umbrella? Are we able to, if we put $1, do we get $1? Do you know off the top of your head?
Mr. Chairman, Senator Hoffman, this is all part of the Medicaid program. So my understanding is any adjustments to the rate system would have to be approved by CMS. If they approve it, then there would be a federal match involved as well.
Senator Hoffman.
The whole conversation about, putting $1 on the table,
that would get you $2.
that'll get you $2 basically if it fits within the CMS. I like this. I think I signed on to this bill.
The feds are only short 30 trillion, Senator Hoffman. I don't see any problem with their capacity to continue to meet their obligations.
And now, Mr. Chair, you're going to have a conversation about block granting this stuff then, right?
That's funny. Not today.
Thank you.
That's not part of even in my head for this year. So anyway, I'm not even going to, I'm not taking the bait. Any other comments for Mr. Goodnow? All right. Seeing none, Thanks, Mr. Albrecht, for getting that fiscal note. Okay, who's next? Mr. Pearson, braving the snow, and Ms. Thurlow, providing oversight. Thanks, Kevin.
Thank you.
Welcome.
Welcome, Mr. Chair. It's a lot easier to drive here when you live in the city than if you have to be on the highway these days, so.
It's snowing out, I'm told.
It's a little snowy and a little cold out there, yes. Mr. Chair, members of the committee, Toby Pearson, care providers in Minnesota, today with the long-term care imperative. We're here to speak about Senator Utke's Senate File 3195. Providing much-needed permanent investments to long-term care. As you've heard in testimony and read in your local newspapers, senior care is struggling to stay afloat. In a word, our challenge is workforce. You've heard this from a number of folks, but ours is just slightly different. This proposal seeks an infusion of permanent money to raise wages to recruit and retain our beleaguered workforce. Then it seeks structural changes to the payment system to address reimbursement issues that have been raised by the COVID pandemic. I'll walk through how the workforce has led to challenges, and then I will turn it over to Ms. Thurlow to explain how this proposal seeks to address those challenges. We also have who we affectionately refer to as our data guys, Todd and Jeff, who will be available if there are really specific issues or questions. First, there's two challenges. Staffing, workforce. And within staffing, we have current and future. Currently, we have approximately 23,000 open positions, or about 20% of our workforce. Now, you've heard us sit down at the table and tell you before how chronic workforce shortage issues are plaguing long-term care. Well, we've reached new heights with this one. In the fall, when we surveyed our members, we were losing about 1,500 workers per month. Our current staff shortages, because we have so few workers, now lead to an ongoing steep drop in occupancy. At first, prior to the vaccine availability and other things, the occupancy decline was related to the pandemic, dropped to about 65%, which is down from which is typically 85 to 90%. Now, because of our ongoing workforce challenges, the inability to admit new residents, the occupancy is not able to rebound. As a result, you still have facilities that are operating somewhere in the 60 to 65% of occupancy. Well, that causes two things. You can't bring in more people to be in your beds, and so you won't make as much money, so you can't pay your workers as much money moving forward. So you start a downward spiral. Or what many of our members have called circling the drain. So the results of our latest survey showed that 75% of nursing homes are limiting admissions. Although not as high, it's still striking that about 35% of assisted livings are limiting admissions. Again, this is not because they do not have open beds. It's because they don't have staff to provide people care in those beds. This has meant that some of you have heard about things like hospital backups. You've also heard reports of entire counties not being able to take folks from the community to serve them. It's clearly a problem if you have an entire county that doesn't have availability of any bed for long-term care. Perhaps equally as daunting, so if that's not enough, you have to look at what our future needs are. We've all heard the state demographer data on the aging of our state. We know that senior care will need more workers in the future. By the DEED data, we are regularly told that among the future highest need professions is healthcare and long-term care. When we already start at such a workforce deficit, it really makes catching up for future needs nearly impossible. Finally, as I alluded to, these things combine for cash flow problems. So despite what has been perceived as lots of federal money going into nursing homes and long-term care, there continues to be more expenses paid out than funds coming in. again exacerbated by the previously mentioned decrease in occupancy. For 2 years, providers have struggled with costs of testing, personal protective equipment. They continue for these 2 years. They're still wearing eyeglasses. It's not just masks and gowns, it's everything for 2 years. Providers have spent reserves, max out lines of credit, and several providers, as I said, have basically told me, we're trying to figure out if under these new conditions we can stay viable. During the latest outbreaks, it wouldn't be unusual for facilities to spend tens of thousands of dollars a week on PPE alone, money they won't receive in their rates for nearly 2 years. One facility estimated they were spending over $300,000 per month in overtime, PPE, and testing costs. You've heard me say this before. When we asked our members about cash flow, about 65 to 70% of our providers say that if the state missed just 1 month payment, they could not go on. Workforce challenges, decreased occupancy, increased costs have resulted in severe cash flow challenges. So now that I've told you all the good news and reminded you of our workforce challenges, I will turn it over to Ms. Thurlow, who will respond about how the specific provisions of this bill and how they seek to address some of those challenges.
Ms. Thurlow, welcome. Are you going to be the happy news person here? Mr. Pearson has depressed us all, probably beyond recovery. So, yeah, go ahead.
Mr. Chair, members of the committee, it would be hard not to sound optimistic after that testimony, wouldn't it? For the record, my name is Carrie Thurlow. I am the president and CEO of Leading Age Minnesota, also here on behalf of the long-term care imperative. So in all seriousness, I do want to thank you, Mr. Chair, for your ongoing attention to our workforce issues. We've really appreciated the interim hearings and focus on this and the ongoing discussion. And I also want to thank Senator Utke for authoring this bill, as well as Senator Housley for her work on senior care issues as well. Mr. Chair, I think you're asking really important questions, in terms of what's the goal in how we solve some of these dire issues and how much is it going to cost? And I would just reflect a little bit that, over the years, we have continually come to the legislature and asked for better reimbursement rates to support our caregivers. That really hasn't changed. But I think that our circumstances, our workforce shortages have become increasingly worse throughout the pandemic in a way that really does demand some significant permanent actions this year. I think it's also important to try to set some benchmarks as to what we are trying to achieve. So the first and fundamental question is, why are we focusing on wages at this point? And, I think it's pretty clear that we are in rapid wage competition right now. Every industry out there, every sector is dealing with rapid wage inflation. And unfortunately, for far too long, caregiving professions, both in our member settings in assisted living and as well as nursing homes, as well as long-term care in general, have sort of been left at this stage of competing with minimum wage jobs. You heard the testifiers before us indicating that direct service workers were around $13 or $14 an hour. That's very comparable to what CNAs and home health aides are making in our settings. Somewhere between, and again, with rapid wage inflation, it's a little bit hard to benchmark it, but it's between $15 and $17 an hour. The reality is these are very skilled jobs that require special skills and training and should not be regarded as minimum wage jobs. Our overarching goal, what we would propose, is that eventually we should be working towards starting wages of at least $25 an hour and having reimbursement systems that can support that. And that, Mr. Chair, is a big number. And I would certainly acknowledge that. What the bill before you for today's discussion does is really three things. The first is that it provides upfront money for nursing homes to help start us on that path towards increasing in a meaningful way permanent wages for individuals working in nursing home settings. The reason that this is important is for all of the reasons that Mr. Pearson outlined. our nursing homes have been financially decimated during this COVID crisis. Because of historically low occupancy that has been sustained over time, we are still at least 10 percentage points below what we typically run in occupancy because of the increased cost. Nursing homes don't have funds right now to provide upfront investments in terms of permanent wage increases. While it is true our current reimbursement system would eventually recognize those investments, providers need that money to invest before they can have it recognized in rates 21 months later. So it is asking for an upfront investment. The second thing it does is actually make some changes to our value-based reimbursement system for nursing homes. Now, I think it's fair to say that when we passed VBR in 2015, the goal was to elevate wages and to sort of help improve wages, and it has done that. But no one considered at the time when we passed it that the 21-month delay would be so ineffective in hampering us to respond to the upward wage pressure that we're experiencing today. So it closes the 21-month delay, and it also removes disparities between direct care workers and non-direct care workers who support seniors through housekeeping, dietary, and laundry to allow those to be cost-based reimbursement as well. The third thing that the legislation does is fully implement elderly waiver rate reimbursement rates. Now, this is actually a law that's on statute right now, but we've only gotten to about 18.8% of 100% implementation, which means we're pretty far behind. In 2019, the Department of Human Services had a study at that time that showed that elderly waiver rates were for the services that they reimburse were significantly below the cost of care. But for example, customized living rates at that time for customized living services were about 30% below the cost of care. So that was before assisted living licensure took place. It was before COVID. So we think that we've probably fallen further behind. And by increasing those rates, we think that we can help those providers also elevate wages in the sector as well. So in the effort of being succinct, I guess I'll conclude by saying again, thank you for this discussion. We're happy to answer questions that you might have and appreciate the challenges ahead.
Comments from members? Senator Murphy.
Thank you, Mr. Chair. Good to see you, Mr. Pearson. We have touched on this as well from the start of this committee, and I listened carefully to the testimony of Ms. Thurlow. I think for the years that I have been serving in the legislature, we've talked a lot about the need to retain a workforce in long-term care and the relationship between that and wages, and we're just experiencing it in a very profound way right now. I do think that we could refer to what we're experiencing in these industries as wage inflation. I think it's probably more accurate to say that we're writing wages in order to meet the demand. That workers are able to, they're able to make choices now, in part because of the number of people that are leaving the workforce, including people who are, at retirement age or a little older. I think that the competition for workers is going to continue, and that's why I think this is an important piece of legislation that is directly responding to a market of workforce that is going to require an increase in wages in order to hold them in a place where we need them. So Senator Utke, Senator Housley, I think this is important work, and I'm happy to work with Mr. Pearson, Ms. Thurlow, and others to make sure that as we look at wages and its interaction with this workforce, that we are making sure the wages are getting to the workers, obviously, and that if we're considering that, we consider it permanently. Thank you.
Well, I appreciate that. Just a tactical question. Ms. Thurlow mentioned an upfront investment or money. I don't see anything upfront. I see 24, 25, 26. Where's the upfront part? Do you know, Ms. Thurlow or Mr. Pearson? Can you point that to me in this? It's only a 3-page bill, I think.
Mr. Chair, members, I think it's referring to the XXX number of dollars per bed given to the nursing facilities, which is how we're framing upfront. And that then would be plowed into the wages and benefits, and then you'd have, the accountability comes from the providers needing to file something saying how they spent the money.
Sure, I just didn't see the XXX part. Do you know where that is in the bill?
I don't have a copy of the bill in front
Oh,
of
well,
me.
I'm presuming it's there. I was going to ask someone to give me a fiscal note on this, and it'll have to be that minus the XXX part, but
Well, so I did ask our data guys kind of a question of, so how much does this actually cost? And I couldn't get an actual number out of them, surprise, surprise, as they're very picky about what the data is you're asking for. But I did get this general response, which was, if you were going to do a $5 increase on just the skilled nursing facilities, it would cost about $700 million, which would actually be about 230 million state share.
all right, I just got I'm on the wrong bill. That probably makes a difference. Sorry. All right, so you said 700 million
It'd be 230 million state share, yes.
per year?
They didn't give me the per year answer.
Isn't that funny? We don't know if it's 1 or 2 years. We're just in this, my tax accountant is living 2 years in the past, and we're talking about 26, 27, and if you have an accident, what year is it? I don't know. I'm not damaged, I just don't know. All right. Well, that's,
I am told that, yes, it's per year.
all right. Okay, and so, Senator Hoffman? Did you say state share is that? Yeah.
Yes, you get a Medicaid match dollar for dollar, and then there's also an interplay with private pay because of the rate equalization law.
Yeah.
Chair,
Senator Hoffman?
there's a phase-in, there's a rate on the disability waiver on the customized living. How is that interacting in there? That just,
We don't have time to talk about that now, so we only have a few minutes for Mr. I'm sorry. You're not going to start getting this DWRS thing going on a turn off his microphone. No more. Anyway, so Mr. Albrecht, if you can get me a fiscal note on that, that would be nice. Another Utke bill we're going to talk about. Thank you, Mr. We're just running out of time, so. Was that funny, Senator Hoffman? I don't know.
absolutely, Mr. Chair, you know where I was going with it, but we will have that conversation.
Yeah, so technology,
good.
just like, come take it away from the sergeant. So, Senator, Senator Wickland, see you, and sorry, I'm glad you were pointed out. So go ahead.
Thanks. Yeah, just a question. I just wondered if there was a mechanism in the bill to tell us, how much of the funding would go towards wages, or is there some commitment? I think I heard Mr. Pearson say something about a report afterwards to say how the money was spent. Can you just say a little bit more about how we might be able to understand how much of the funding would go toward wages, and then maybe we can see that also in the fiscal note as well, and then that after report. Thank you.
Yeah, Mr. Pearson.
Yeah, Mr. Chair, Senator Wickland, that's a good question. The goal here is to make sure that there's accountability on how it's spent. And so what we have started off with is similar to what we've done in the past, which is you have to demonstrate to DHS how it was spent. And that it's similar to the auditing, except you have to do it up front. So the goal is definitely the accountability for wages and benefits, and if we need to improve the language to verify that, we're open to suggestions and working with folks on that.
But it's not now encumbered compared to some of the rate increases we've done.
Mr. Chair, I think how we would envision it is that, yes, this is the best we can do for encumbrance in the VBR system.
Okay. So that's as good as we can do, Senator Wickland. So we'll keep touch of that. And I know that we all want a lot of the money to go to the workers. And I don't think that, I suppose they could just sweep it out and do something else. But anyway, so, and so later on, Mr. Monahan, just to help me out after this discussion today, can you just give me a list of what groups we've left out that we are usually interested in terms of the home health and that, like, anyway, our usual inventory. So welcome, Mr. Bergeron, and definitely not least, but anyway, you are batting cleanup today.
But last
so
nonetheless.
Welcome to the committee.
Thank you, Mr. Chair. Members, my name is Matthew Bergeron. I'm an attorney with the law firm of Larkin Hoffman. I'm here today on behalf of the Minnesota First Provider Alliance. They're the statewide association of PCA agencies. PCAs in Minnesota serve over 44,000 residents and employ about 66,000 PCAs. You would be hearing from the Provider Alliance's president, Ms. Dina Belisle, but unfortunately, she was unable to find PCA services to cover and care for her son, Anthony, and has asked me to testify on her behalf.
That's just amazing. Hello, anyway.
Thank you all for the opportunity to talk really briefly today about Senate File 2967. This afternoon, we've been talking about the various rate frameworks that we have in place in disability services. And up until all the work you did last session to pass such a framework for the PCA program, there was no framework. There was no accounting for the cost of providing services. There was no data collection related to the wages and benefits being paid and provided in this essential service. It was a Medicaid rate. Sometimes it ticked up, sometimes it ticked down, and there wasn't really anything kind of driving a lot of those decision-making pieces until the Provider Alliance, working with a variety of others of PCA Reform Coalition, brought together a proposal that Senator Utke carried last session, and working with you all, were able to get into law. However, and I want to note this in kind of the context of the conversations we've had before, facing some really crisis reimbursement situations, there were a number of elements of the rate framework that had to be dropped away to ensure that all the dollars that you all had available last session were able to go into the rate as soon as possible. We were facing a situation where frankly, but for the actions you all took last year and the substantial investment in this program, PCA services could very well have collapsed, particularly in the Twin Cities metro area. And so, in doing that, you all made the right decision to in my opinion, to save the program in the short term by taking out the various elements, the BLS data rebasing, the competitive workforce rebasing, the phase-in, the biennial phase-in of the implementation factor to get us to a fully funded rate framework. In the moment in time, in the crisis we were facing, that was the right decision, but that remained some work left undone. And that's what you all have in front of us. I would note today that Senator Utke's bill before you would get the PCA program, frankly, to where the other programs you're hearing from today are starting from. So this is not the bill that necessarily gets you to $20 or $25 an hour. It would get us, a bump. It would also give us the opportunity to have some structural growth over time in the way some of the other reimbursement rates in this space have historically been adjusted and calculated. And it also would give you the opportunity to look at things like the implementation factor, and instead of every 2-year adjustment kind of built into law, every 2-year 2% adjustment built into law, being able to recognize the fact that right now it's at about 75%. And so you'd have the opportunity to move more quickly to at least fully funding based on the data we have now, let alone taking into account some of the cost data and wage data that we know is evolving over time and driving up the cost of providing these services. So the bill before you today essentially has 4 baseline components into it that would build in kind of that responsiveness to wage and cost data and the implementation towards a fully funded framework over time in front of you. So that's just kind of the quick overview of the proposal in front of you today.
Thanks, Mr. Bergeron. How many PCAs are there? Do you know?
About 66,000 is my understanding.
Yeah.
That's full and part-time.
Sure. Questions from members? And Mr. Albrecht, if you want to get this fiscal note too, that would be dandy. Well, I don't know. I mean, the whole story is, what I can't figure out is why aren't we full of media like, oh, this is terrible, what's going to happen? And And every test, you were pretty, restrained in your comments because we heard it already from the other ones, but about the challenges that face us and people being secure and whole and alive in the services and having somewhere to go. So we're going to keep beating the drum here. I hope it matters that we can do this, but you've persuaded me, and I think the committee is pretty persuaded that we had better do something. So, so I just have a few closing comments, unless anybody else has a comment besides. So when we come back on Thursday, I don't know what order. I think we'll let maybe Commissioner go first, just so she can have a time certain. Talking about the RCOs, and if she wants to talk about the behavioral health transfer, whatever bill number that is. And then also, if the DHS staff could provide for us, just to kind of distill down the governor's budget and help me understand, just with certainty, the elements of that budget that relate to the topics today. I know there's a couple things. I know there's the $115 million. And I would like, when they came, there was just this 6-page kind of story about what might happen. But if they could, I know Ms. Grom referenced that there's going to be some impact, and so they must have some idea about what impact might be. How many staff will be, how many places will be preserved, or, just what impact, without knowing what grants are going to be applied for, but what they kind of anticipated, because they must have come up with that 115 million. It's an odd number even, so they must have had some idea. It's like 6 different digits in our no zeros parlance. And then also, I think the governor has a hero pay proposal in his budget. I'd like to just have that enumerated and who he includes on that. And then if there's other elements that are going to address the concerns we had today, which we consider to be beyond a crisis, what elements of the governor's budget would be addressing that? As he spent his $555 million and the $2.2 billion. That would be very helpful. And if that could be part of the commissioner's presentation or a separate one from somebody else. And then we'll continue our work and we're going to continue the dialogue about ways to improve workforce. And I think we're open to takers if somebody else, right? So if some of the groups watching want to come back and revisit their topics based upon the feedback, my goal is to get a committee kind of a bill, particularly get the non-cost stuff and the for-cost stuff. I have no idea what our omnibus is going to look like. It may be preciously small. I don't know. I know I'm pushing on a workforce package personally. And the other things are important. So that's what I see going forward. And then, like I mentioned, Tuesday we'll do some bills, and we'll try to keep you somewhat apprised about what else is going on. I don't see us moving any bills. Oh, and then on the homeless day, we're going to do some work with Senator Dibble. So I already said that. I'm repeating myself. Sorry. Anyway, with that, drive safely. We're adjourned.